Hi, I'm Nadine Jacobson, and I'm going to be presenting today on interventions for young adults whose cannabis use is concerning. This was an integrative review and was completed for an evidence-based practice course with the University of Central Florida with Dr. Lindo. I'm a registered nurse and an attorney, and I also have a master's in nursing health policy. Cannabis use is pretty prevalent in the United States and many other places in the world. It is often the illicit drug of choice for young adults. 1.1 million young adults started using cannabis within the preceding year. Cannabis use can have detrimental effects on psychosocial functioning, such as academic achievement. It can cause altered neurodevelopment, particularly if started at a younger age by adolescence. It can cause large airway inflammation and bronchitis and does have an increased risk of psychosis. The purpose of this study was to answer the following PICO question. In young adults ages 18 to 25 whose cannabis use is concerning, how does an intervention compared to standard care impact cannabis use measures? The electronic databases CINAHL, Medline, and APA PsycInfo were the databases used for this integrative review. And as can be seen here, this was the search strategy and the search terms that were put together with the assistance of librarian of Mr. Andy Todd, the librarian for the School of Nursing at UCF. Inclusion criteria were quantitative intervention-based research and cannabis users between the ages of 18 to 25. Exclusion criteria involved studies with a biomedical emphasis, animal studies, CBD studies, therapeutic, medical, or pain management studies, unintentional exposure to cannabis studies, criminal justice focused studies, psychometric studies, and qualitative studies. "34 articles remained for full-text review from the first and second searches. 12 articles were excluded in full-text review, 11 from the 5-year date restriction and 11 from the no date restriction. 10 articles remained for the purpose of this project. The PRISMA flow diagram was followed, as can be seen here. The levels of evidence were ascertained using Melnick's hierarchy of evidence, and one can see here that there was a level 1 systematic and meta-analysis. There were 8 randomized control trials, which were level 2, and then there was a level 3 quasi-experimental study, which was a non-randomized control trial. As far as the results, initially, all of the kinds of interventions in the 10 studies were cataloged in this table. There was motivational interviewing, motivational enhancement therapy, cognitive behavioral therapy. There were many of the approaches were combined, and this was used as a way of categorizing them by calling them combined approaches. There were harm reduction approaches. There were prevention programs. There were digital, internet, computer, social media programs, interventions, contingency management. Contingency management refers to a a reinforcement program where abstinence is encouraged, and then there are rewards given for abstinence. There were individualized interventions such as personalized feedback intervention, and there was also one called distress intolerance or distress tolerance, which later on was put in the cognitive behavioral therapy category. There were a couple interventions that involved dual diagnosis or comorbidity, particularly for anxiety. Some of the interventions were brief interventions, and there were the controls, which were drug prevention as usual, assessment, educational brochure, enhanced usual care. There was also something called community reinforcement approach, solution-focused therapy, counseling, extended intervention, and individualized assessment and treatment program. A further list, a further organization of these kinds of therapies narrowed them down to these categories. The most common interventions were cognitive behavioral based therapies, and there were 7 of these, and motivational based therapies. There are also 7 of these out of the 10. And the next one, which isn't actually a therapeutic approach, but it did get its own category, and there were 6 of these, and that was called digital, and those were the internet and computer and social media approaches. Then combined approaches, there were 5 of those, and then the personalized, individualized approaches, there were 4 of those. There were 3 brief interventions and 3 contingency management interventions. As far as themes, there were 2 categories of themes, and each category had 2 subcategories. The first category was interventions for reducing cannabis use. The sub-themes for this was combined therapeutic approaches usually included CBT, and marginal effectiveness of interventions. The second theme was intervention strategies geared toward young adults, and the sub-themes were young adult tailored approaches not consistently reported or implemented, and kinds of young adult tailored approaches. For the combined approaches, which usually included CBT, I'm not going to go through all of these results, but just leave this here for a second and just briefly discuss that there were, again, we see that they usually included CBT. So as far as evidence-based practice, one could make the recommendation that using an approach that is combined with cognitive behavioral therapy will result in some positive outcomes generally. There was the theme of marginal effectiveness of interventions. So in the study by Baines using MET with CBT, they found a statistically significant decrease in percentage of days using cannabis at 3 months. And in the study by Bonar and colleagues, they reported that vaping days reduced statistically significantly in an intervention using motivational interviewing and CBT. And in the study by Buckner and colleagues, they suggested that self-reported cannabis use decreased to the same extent for both conditions over time. And in the systematic review meta-analysis, they found a statistically significant reduction in the use of cannabis after treatment interventions that use digital delivery methods, because that was the focus of that systematic review and meta-analysis. And in the study by Copeland, where they were looking at MET, they found quality of past month cannabis use decreased statistically significantly in both a brief feedback group and in an extended feedback group. And there are similar findings in the remaining studies. So the theme of young adult tailored approaches not consistently reported or implemented. Some of the studies discuss specifically how the intervention would be engaging to young adults, who are also often referred to as emerging adults. The study conducted by Bonar and colleagues recognized how the behavioral interventions being utilized were tailored to appeal to the developmental level of emerging adults. So some of the kinds of young adult tailored approaches that were seen in these 10 studies were the use of social media. In this case, it was Facebook as a platform. There was a Facebook private group that was moderated by e-coaches. There were age-specific consumption issues. They discussed the influence of peers. Reinforcement on how to spend time with friends without using substances was discussed. The manual that was compiled in one of these studies took into account participant comments. In one of the studies done, that was with general practitioners, or in otherwise referred to as in primary care. The GPs said that they felt free to adapt what they were saying based on their appraisal of the individual young adult. And they noted that young adults were more likely to confide in the GPs if they were alone in the room with the GP. So, strengths of the 8 RCTs were that they had robust statistical analysis, that they found that longer interventions tended to work better. Some limitations: the systematic review meta-analysis reported that many of the RCTs were low-level quality, and the study designs were heterogeneous, and it was very difficult to make clear recommendations because of the designs being so different. Also, in many of these studies, there was a therapeutic intervention being compared to a therapeutic intervention, and one being found significant over the other. So there weren't many that just had a control group that was not really having an intervention. Harm reduction approaches is a concept that was noted, and that they promote better public health benefits. And the feasibility of use in clinical practice: some interventions like motivational interviewing can be used by nurses and are used by nurses. Other approaches could require additional training, and this could be a bit of a problem for nurses to be using these approaches. However, if nurses know about these interventions and the effectiveness, they can also inform their patients and their clients about different options available to them. So in conclusion, cannabis use by young adults can be problematic for many, especially if it progresses to conditions like cannabis use disorder. Many interventions have been explored with mostly small effects. Nurses should be aware of intervention options available to young adults, however. With expanding availability of cannabis and increasing potencies, nurses can play an important role in mitigating the problems young adults may experience to their health, as well as with associated social problems. There is definitely more research needed in this area, and there are significant policy implications. Thank you very much, and I look forward to your comments and questions.